Hello, everyone, and welcome back to our NCLEX-R review. And for those who just joined us, we're on the 6th day of the 90-day free NCLEX review classes, which we schedule daily at 12 p.m. Eastern Standard Time. And we are covering all the nursing subjects and rationalization of 2000 NCLEX-style questions. But today I'll talk about the nursing care and also the management for an adult patient with renal calculi, and we have some Q&A right after. Now, let's define first what is renal calculi, which is basically the same as nephrolithiasis or urolithiasis. Well, this is a problem that is going to involve the formation of a calculi, or basically a stone, in the urinary system. And we have to know that there are different locations of the blockage. It could be in the ureterovesical junction, which is basically right here, close to the bottom of the ureter. And the reason for that is because it has the narrowest lumen, okay? And so the ureterovesical region is the narrowest part, and as the ureter approaches the bladder, it constricts and making it a common site for stones to become stuck. And also the entry, there is some kind of an angulation wherein the ureter enters the bladder at an oblique angle, which can really create a natural bottleneck. And this can impede the passage of the stones, and of course, increasing the likelihood of the obstruction. Now, we also have another common site of the obstruction, which is the renal calyx, which is basically right here. And also the ureteropelvic junction, which is right over here. And also that section wherein the ureter crosses the iliac vessels, which is near the pelvic brim. Now, guys, you really need to know also the corresponding precipitating or predisposing factors. And one of those is the insufficient fluid intake. And this is the most prevalent and also avoidable risk factor leading to concentrated urine and also crystal formation. Now, there's also an involvement with hereditary predisposition and also conditions that are associated with the stone formation. And one example here is the gout, wherein there is an excessive or high levels of the uric acid. And this is going to be filtered by the kidneys. Of course, this can lead to that as well. Now, another problem is the Crohn's disease, which is known to have an excess amount of the oxalate. And the third one here is the hyperparathyroidism, wherein there is some form of hypercalcemia going on. And so with the excess calcium ion circulating in the bloodstream, there you go. It ends up in the kidneys. Now, there is also a type 1 RTA, which is increased urine pH. This is known as the distal RTA. This is going to cause the kidney to have an inability, or it will not allow the kidney to acidify the urine in the distal tubule of the nephron. And so what's going to happen here exactly is that there will be an abnormal buildup of the acid in the bloodstream while the urine becomes inappropriately alkaline. Now, that is why it's called the A or the RTA. So the acidosis basically is going on inside the bloodstream, not in the urine. Now, there's also the reason that there's an impaired hydrogen ion secretion in the RTA type 1. And so, again, the distal tubules of the kidneys will fail to secrete the hydrogen ions, and again, it will be unable to produce the sufficient acidic urine. Now, because of that, the buildup of acid will happen in the bloodstream. Again, that will cause the metabolic acidosis, and this can do a lot of complications inside the body if untreated. Now, also, there is some form of, let's say, kidney stones by the effect of some pharmaceutical agents, and this is caused by the loop diuretics. And we know for one, we have the Lasix or the furosemide, and it can cause high calcium levels in the bloodstream as well. Now, we also have that acetazolamide, which is another diuretic. And this is known to increase the pH of the urine. Now, think about for those people that are really using antacids for their heartburn or, let's say, gastritis. So they are prone to developing kidney stones as well due to the ingredients and also some cancer treatments that could possibly cause lysis, especially when the dead tissues, those cells that have been killed by the medication, this will now end up as a uric acid stone. Okay, and so you have to think about those cancer patients developing kidney stones. And another is the crystallization of the urine caused by some known medications, such as the acyclovir, which is used to treat chickenpox, and also sulfadiazine. Okay, so take note of those medications that are going to place the patient at risk to developing kidney stones. Now, another factor here is the male gender, and they are known to have at least 3 times more risk to develop kidney stones. And as I have researched about this, well, there is an involvement about the dietary factor, wherein possibly men consume diets higher in protein and also salt, which can contribute to the formation of kidney stones. And foods that are rich in oxalates, such as nuts, and for those who are really fond of chocolate, there you go, that can also increase the risk. Now, there's also involvement about the occupational factors in men. Maybe this will predispose them to dehydration whenever they are working in the hot environment or jobs that don't really allow for frequent breaks. So that would be unfortunate. Now, another is the incidence of urinary tract infections. Please take note of this because this is something that could come out in your exam. Urinary tract infections can actually lead to formation of kidney stones, and especially those urease producing bacteria. They are known to cause the struvite stones. So we will go over the different types of stones later. Now, there's also an involvement with the dietary habits, especially low calcium. That's kind of weird, huh? There's low calcium, but high in oxalate intake. So both of these are actually going to lead to excess oxalate, wherein there is a high calcium intake, and it's rarely linked to increased stone formation. So we will dig deeper into this discussion. Now, we are going to talk about the different varieties of stones. And this is something that could potentially come out in your test, especially if you're going to provide some teaching. What dietary modification that needs to be done at home whenever they have this particular stone. And so we're going to identify those 4 different types of stones. And though we have calcium stones first, and this is something that can be caused by an acidic urine. It will favor the formation of the calcium oxalate stones. Please take note of that. This is something that's not quite shared often. And also, if there is an alkaline urine, it can promote the development of calcium phosphate type of stones. Please take note of the 2 differences here. For the acidic urine, it will favor the formation of calcium oxalate stones, whereas in alkaline urine, it can promote the buildup of the calcium phosphate type of stone. Those are typically 2 different type of calcium stones. Now, we are going to describe what these calcium stones are. And of course, they are the most common type of stones. They comprise about 80 to about 85% of kidney stones. And then the alkaline urine, again, it will favor the formation of calcium oxalate. Calcium oxalate, is it? Right? Yeah, the acidic rather. And also the alkaline urine will favor the buildup of the calcium phosphate stones. Now, talking about the shape of the stones here, they are known to be bipyramidal, or they're seen as biconcave oval. And when you're looking into the radiology study here, especially like a regular abdominal x-ray, they are visible. Okay, please take note of that. Calcium stones are visible in the abdominal x-ray. Now, talking about the next type of stones, which are the uric acid type of stones, and they are caused by a problem in the gout metabolism. Okay. Now, also chemotherapy, especially with high cell turnover, wherein there is a rapid breakdown of the purines from the dying cells, this can also increase the uric acid in the bloodstream, which will further go down into the kidneys. Well, there you go. You have a uric acid type of kidney stone. Now, this is something that is going to occur if there is persistent acidic urine, especially if the pH is less than 5.5. Please take note of that. Uric acid, or yes, uric acid type of stones can form much faster if there is an acid urine. Please take note of that. Now, as far as its percentage in the occurrence of different stones, it comprises about 10% of all kidney stone cases, and its shape is about flat square. And this is something that's not visible really in the abdominal X-ray, right? So take note of that. It's not visible in the abdominal X-ray, and this is on the uric acid. However, though this can be detected by other imaging studies, and we'll expect that the CAT scan or the ultrasound in the abdomen or the intravenous pyelogram will be used in order to detect the uric acid stones. Now we'll talk about the struvite or the staghorn type of stones. So what is this? Well, they are known, or they're called as staghorn because they represent like one of those antlers by those male deers. And so they have like branches, just like an antler of a deer. Okay. And so this can occur in those patients that have recurrent urinary tract infections, wherein they have those kind of UTI that has that urease producing bacteria, like the Proteus, Klebsiella or Serratia, or the Enterobacter. So please take note of those common urinary tract infection microorganisms, and they are going to cause the staghorn and the struvite type of stones. Now, this is a kind of type of stone that will thrive in an alkaline urine. Please take note of that, alkaline urine. And so this is also associated with the urea splitting bacteria, wherein they're going to convert the urea to ammonia that will create the alkaline urine. And so when the ammonia combines with the magnesium and also the phosphate, they're going to form the struvite stones, which can occupy the entire renal collecting system. So this is really going to be one of those major invaders in the renal collecting system. All right. And remember that they have that odd shape. They have that like antler looking ends, which really can cause erosion into the renal tissue. Now, with the description of this type of stone, it comprises about 5 to 10% of total kidney stones. And again, they have that staghorn look, and they're actually going to look like a rectangular prisms in shape under the microscope, and they are visible in the radiology study. Okay, so the regular abdominal X-ray will be able to visualize this kind of stone. Now, talking about the cystine stones, this is going to be caused by a genetic predisposition, mostly the cystinuria. And this is something that can comprise about 1% of all kidney stone cases. And it has that hexagonal shape. And this is not easily visible in the abdominal X-ray. And so when this happens, there will be imaging studies that will be required in order to detect this type of stone, which are the CT scan or the ultrasound of the abdomen or the intravenous pyelogram. Now, please take note, guys, that the disease progression and, of course, the growth of the stone actually, especially when the stones are larger than 1 centimeter, and they are not going to likely to pass on their own. So This is the kind of size that would really get stuck into the small passageway, especially the ureter. And for those stones that, let's say, are smaller, maybe a half centimeter or 0.5 centimeter, they are going to typically pass spontaneously. So lucky if you have that kind of small stone. But for those who have larger stones, this can really cause obstruction, and it will probably cause the post-renal loss. And this can really lead into the acute renal failure if not detected right away. Now, the recurrence of the kidney stone is going to be frequent, and up to 50% of the patients will experience another stone formation within the next 10 years of their occurrence. Okay, so please take note of that. It will recur. So there will be periodic testing of the urine pH as well, and also making sure that this is going to be prevented by, let's say, medication prescription. Now let's talk about the clinical features of the kidney stones. So there are only a few that I'll be sharing here, and because these are the only important manifestations, and one of that is actually the severe colicky renal pain. This is the topmost manifestation that the patient will be telling you or reporting. This is a pain that is really associated with the passing of a kidney stone in the ureter. They can actually feel the movement of the stone. And so the pain will be based onto that movement. And when this happens, it will really get lodged. It will obstruct into the ureter, and it will eventually cause spasm. Now, the kind of pain that will be described by the patient here, it will be sudden, and it will become more severe. And the patient cannot sit still, usually writhes in excruciating pain, and may occur in waves or paroxysms. Now, as far as the location, though, it will begin in the flank area, and it will also radiate anteriorly in the abdominal area, the front portion, and it will radiate to the groin, which will follow the path of the stone. So basically, in the anterior aspect of the body. Please take note of that severe colicky pain starting from the flank area and radiating into the lower abdomen, okay, and to the groin area. Now, we'll talk about the next manifestation, which is very common, which is nausea and vomiting, which is basically going to accompany the pain. And the reason for that is because of the intense pain from the renal colic. This will stimulate the nerves that connect the kidneys and also the GI tract, and thus triggering the nausea and vomiting as a reflex response. Now, moving into the next manifestation, which is basically the hematuria. And this is common in over about 90% of the cases. And I've seen many of my patients back in med-surg having the kidney stones. Yeah, they can be really demanding as far as like wanting their pain medication because it's very intense. We totally understand that. And I don't want any kidney stones bothering me. And so once they get to you as your a brand new patient, you've got to be prompt in delivering those pain medications because this is no joke. And so it is associated with the hematuria as well. And so there will be presence of like blood tinge that you will see in the urine output. And it might scare you if you're not really experienced to deal with this patient in the past. So it's like, what is this pinkish looking urine? It's just like a cranberry juice, really. I've seen those. And the reason for that is that the kidney stones will actually scratch and irritate the lining of the urinary tract as they are going to move along the urinary tract. And this will cause the bleeding. And so that's why there will be presence of the red blood cells when you're collecting the urine sample when they were sending it to the lab. Obviously, of course, right? Now, we're going to talk about the urinary tract infection. And this is something that will always accompany the kidney stones. Never missed. And so the reason why urinary tract infection can develop, that's because the obstruction that is caused by the stone can also lead to stasis of the urine. And I'm talking about the stasis in the urine in the upper portion of the renal system, not in the bladder, not in the urethra, but actually in the upper portion of the urinary system. It could be in the pelvis, it could be in the parenchyma itself, or it could be in the ureter, just right above the blockage. And so this stasis of urine will actually become a favorable environment for the bacteria to grow. And also with the presence of the stone, this can damage the urinary tract lining, and this can be a pathway for the microorganism to cross the bloodstream. And so, yeah, I've had patients that develop sepsis, and I've had an experience with an elderly lady. She wasn't really complaining of the pain, which was kind of weird, but her urine color was really pinkish, like a cranberry juice. And so the plan was for this lady to have a placement of a stent by the next day, and I was working night shift. And so there was already detected changes in her blood pressure. It kind of leaned towards the low hundreds for the systolic. And by 11 p.m., I already noticed that the systolic went down a little bit more to the 90s. And the diastolic was in the 50s, 60s. So I was kind of on my toes already. And the patient was already NPO because I was preparing her for the stent placement. And she was complaining much more of the nausea, which is kind of weird. Not a whole lot of pain. She was still urinating. It was not fully obstructing yet the pathway of the urinary tract, but the urinary tract infection has been an issue during my shift. So I ended up giving IV bolus with normal saline solution to this patient. And unfortunately, it was just kind of hanging around in the low hundreds, but I wasn't really comfortable keeping that patient in my unit. And so I transferred her to the ICU. And they actually postponed the procedure. They wanted it to be done the next 2 days because they wanted to really treat the sepsis first. And so, yeah, you gotta be really on your toes when you're dealing with this kind of problem because it can be life threatening, just like with that lady. And so, yeah, with the erosion of that stone causing that tissue injury, it can allow the microorganism to cross into the bloodstream, causing sepsis. I got distracted again. And so let's move forward here with regarding the different diagnostic tests for the renal calculi. And so it is very common. First things first, the medical provider will order urinalysis. They would be mad if you're not going to collect this as soon as possible because this is the one of the preliminary testing that need to be completed, right? You better collect this one. So the urinalysis is ordered, and the reason for that is it can identify the microscopic or the visible blood in the urine through the microscopy. Yes, they can detect those red blood cells in there, and also it will detect the urinary tract infection. Also, if there is now pus cells or let's say bacteria is already present, yeah, it will be caught. And then it will also analyze the urinary sediment of various crystals. It will actually determine if it's a calcium, it could be cystine, or it could be uric acid or struvite. Now, the urinalysis will also measure the pH, the acidity or the alkalinity. And so if the urine is alkaline, this will probably signify a urease producing bacteria causing the infection and also causing the stones, while an acidic urine will facilitate the growth of the uric acid stones. So I really want you to get familiarized with the different associations of the stones and also with reference to the acidity and the alkalinity of the urine. Now, the next study that we need to anticipate here is the collection for the urine, and this is intended for culture. And we're going to conduct this if we are suspecting any kind of an infection, and we can tell or we can detect what kind of causative bacteria is in the urine, right? And most of these people really will have their urine cultured because, let's say, the elderly people, especially those women staying in the nursing homes, they're not really drinking enough water, and also coupled with the poor um, hygiene, they are going to be prone to developing the E. coli type of urinary tract infection. It's too sad. Now, the next testing that we're going to expect is a 24-hour urine collection. And this is going to evaluate the different levels of the creatinine, the calcium, the uric acid, also the oxalate and citrate. And this is only going to be done for patients with recurrent stones. And this is to identify the risk factors and also the underlying causes. Now, we're also going to expect another testing, which is going to be the serum chemistry or the chem panel. And so we will be looking into the blood urea nitrogen and also the creatinine if there is already an involvement with the kidney itself. Like, let's say, maybe if there is now an obstruction of the stone, which will cause a post-renal type of acute renal failure, there is a backflow. It can really cause some malfunction in the kidney, known as the acute kidney injury. And so we're going to look if there is now an effect in, let's say, trapping those waste products like the BUN and the creatinine. They should not be in the bloodstream, but should be excreted. But here, possibly there is now an elevation of those two because of an undetected obstruction. Now, we're also going to look into the calcium, the uric acid, and also the phosphate. And the stone analysis would really benefit because this will determine the chemical composition and this will really guide the treatment plan. Because if the stone is identified as such, let's say an oxalate or a calcium or a cystine, or it could be a struvite, then there will be a modification of the client's diet and also ways to acidify, maybe to alkalinize the urine. So there is so much of a differences in the interventions here because it really depends on what kind of stone it is. So it could be to alkalinize the urine, or it could be to it would also probably require acidification of the urine. You really need to pay attention to what case your patient have. Now, at this point, we're going to talk about the different diagnostic tests. And so here we go. The KUB, or known as the kidney, ureter, bladder, which is a radiologic study. It's a plain radiography, and this is going to be the first test that will identify the stones. Like I've said, some of those stones will not be easily seen. And like the cysteine and the uric acid, those are very kind of like they're trying to hide. They can't be visible in a regular abdominal x-ray. And so the doctor has to order a different imaging study in order to capture those. And so we have the CT scan or the spiral CT without the contrast. And so this is really the gold standard for diagnosing the kidney stones because this is the most sensitive test for detecting any type of stones. Okay, again, that's the gold standard. It can detect all types of stones, including the radiolucent ones, like the uric acid and the cysteine stones. Now, another testing here is the IVP, or known as the intravenous pyelogram. And we definitely need to do our judgment here as nurses. Remember that this is going to involve the use of a contrast media. So I'm going to ask you right now, what is your preparation for the patient before sending them to the diagnostic room? I want you to say your answers right now. If you had answered it, that's good. And so one of our responsibilities here is to check the allergy of the patient, if they're allergic or sensitive to any contrast media. Okay, because this will require the injection of the contrast media to facilitate the visualization. So you really need to obtain that information. Okay, and if in doubt, always ask the family members and also review any past medical history. This would really become a lifesaver to your patient, or else your patient is going to develop an anaphylactic reaction while in the diagnostic room. We don't want that either. And so another is to check for the patient's renal function, let's say the creatinine level, also the GFR, because this is a substance that can get easily collected, or it probably will not be excreted well by a malfunctioning kidney. And so this will also cause some more problems in the kidney function if we are not screening our patient for their renal function. So take note of those preliminary nursing and or assessments. Okay, so please take note of those. Now here with the intravenous spielogram, we need to also assess the degree, and this is a test that will actually assess the degree and also the extent of the urinary tract obstruction. Because the medical provider or the radiologic technician will actually see the imaging here, because this is done in real time. So this will really visualize that area where there is an obstruction. However, though, this is something that is not usually required for diagnosing the kidney stones, but it might be helpful in determining if the procedural intervention is really needed. Now, next on our list here is the renal ultrasound or the abdominal ultrasound, which is really going to help with detecting any kind of swelling in the kidney. We call it as hydronephrosis. So there is some kind of a fluid collection in the kidney parenchyma, in the calyces, inside the kidney, basically. So it's swelling because of the trapping of the collected fluid. Instead, that it goes down into the lower urinary tract, because there is an obstructing stone in the ureter. The urine that is formed by those glomerulus or the nephrons will be backing up, and so it will drown the kidney tissues, and again it will cause the swelling of the kidney. All right, now this can also cause ureteral dilation. Okay, so this is what we call as hydroureter, if there is backflowing of the urine into the upper section of the urinary tract. Now, this might give us a false negative results in early obstruction, and also the renal ultrasound has a lower success rate in visualizing the stone. So again, our gold standard is the CAT scan without the contrast. Now, why are we gonna expect the use of an ultrasound? Well, maybe for those patients that are not supposed to be exposed to radiation, especially for those pregnant women in their early trimesters, then this is their option, okay? The use of the renal ultrasound. Now, we're going to talk now about the different modalities of treatment, different procedures in getting rid of the kidney stones. And I'm sure you have probably known some of these already, but we need to go through each one of them just to kind of remind you of some stuff that you might have forgotten. And so one of those procedures is the ESW, which is the extracorporeal shockwave lithotripsy, or just lithotripsy. Just make it that easy. And so with this testing, this is going to involve the preparation of the patient. We want to make sure that they are placed NPO, at least 6 to 8 hours NPO for solid foods, and at least 2 to 4 hours for the liquids. Please take note of the different parameters here, okay? And it might vary a little bit from one institution to the next, but I'm considering mostly the general preparation here, and so that's why I've listed those two. Now, this is going to also include the obtaining the consent of the patient, and this is really one of the mainstays in the treatment. This is a non-surgical method for treating the kidney stone, and also if the kidney stones is about the size of 4 millimeter and 2 centimeters in size, and they're going to be visible in the x-ray. And so the mechanism here for this treatment is that the high energy shock waves that are going to be used will break the stones into the small fragments, and that can be passed into the urine. Yes, they're going to break those stones into smaller pieces. And so that's how powerful those waves are. And this really can allow the passage of the stones just right there and then. And so, what is the patient's position at this in this procedure? Well, the patient will probably be on a table, on a special table, and also maybe in a different manner, they're going to be submerged into a water bath or an adjustable stretcher with some water cushion. And so, in the water bath setup, the shock waves will travel through the water and around the patient. While in the cushion setup, a gel layer will actually be placed between the stretcher and also the water that will help transmit the waves. So we're not really going to be asked on the positioning in the NCLEX. I'm just giving you a little bit of overview, but our care here post-procedure will be the most important thing. Now, the reason that I'm talking about this is because this is a test that will also allow us to determine who's going to qualify and who's not. And so the one of the advantages here in having the ESW is that this will really most patients will avoid having the surgery, and also the procedure can be repeated for new stones without damaging the kidney function. And so there are some disadvantages though. There are some complications. It can cause pain during and also after the procedure, and it can also lead to urinary tract infections. There's kind of like very weird mechanisms going on, but it can possibly lead to the urinary tract infections as well, and some bleeding around the kidney. Well, of course, maybe during the procedure, there will be jarring of those stones and will cause some erosion into those kidney tissues, or it could be the ureter. And so that's why it can cause bleeding. Now, this is not very suitable for pregnant women, and so they are not gonna be able to undergo this kind of procedure. And for those patients that have untreated coagulation disorder, so if they are known to be bleeders, they're not supposed to be treated with this kind of modality. So bleeders, coagulopathies, pregnant women will not be qualified to have this kind of procedure. Please take note of that. Now, as soon as a patient returns to the unit after the ESW, it's very important that we are promoting their fluid intake. And even so, if they're able to take in lots and lots of water, we also have probably going to be asked to infuse fluids, IV fluids, in order to flush the urinary system to make sure that those sediments will be carried down to the lower part of the urinary tract and then finally urinated or voided. But our intervention just doesn't stop on pain management, monitoring the color, blood pressure measurement, or vitals, or hanging the IV fluids. No. Even so, if they have already undergone the ESW, our task here includes straining the urine. That is very important. Make sure that before the patient returns to the unit, or even before, when you, let's say, you are the nurse that will be admitting a new patient with a diagnosis of kidney stone. For me, as a nurse, I actually would collect already those strainers before the patient arrives to the unit, before I get the report. Just everyone will know that this is what I'm going to do. This is my standard. My CNA should be doing that. And everyone who's going to be involved in the care should be straining the urine. Even when I'm going to be on lunch or taking my break, they should be straining the urine. That's my practice. And so that is very important because we are going to have to collect those sediments, and this will be tested for the kind of stone they are, and this will be determined as well in order that we can modify their diet and also modify the treatment. Now, another testing that is expected to be done is the percutaneous nephrolithotomy. And so the same preparation will be done to the patient. There will be an NPO of about 6 to 8 hours for the solid foods, and then about 2 to 4 hours for the liquids. It will also require signing of the consent. This is also a procedure that is invasive. Okay? Any kind of invasive procedure will require consent, And if you are not familiar with the preparation as far as like putting them in NPO, always check the guidelines. It doesn't hurt. I always do that. If the policy doesn't state any of the diet restriction, then I have to go into the regular nursing book. That would I would always do that, and I want to make sure that I also clarify it with the radiology department in order that we will coordinate. Now, that's only going to happen if I'm unsure, right? Now, also, we're going to be, we need to know that the percutaneous nephrolithotomy is indicated for those stones that are larger than 2 centimeters. And if they're going to lodge into the collecting system of the upper ureter. So that is why this is going to be used as one of the procedures, those stones that are around greater than 2 centimeters. Now, the procedure will actually involve insertion of a needle, and it also will, the insertion of the needle will be near the collecting system. And of course, this is going to be done in the diagnostic room. And also, there will be a guide wire that will be introduced into the pelvis of the ureter, and this will now be followed by the placement of an inflatable balloon or also a dilator. That will be followed by a nephroscope, a grabber, in order to capture that stone. So that's kind of fascinating to see if you're going to be able to see this kind of procedure. So again, the procedure will involve the placement of a needle, and it will be guided into the kidney's collecting system with, of course, with the fluoroscopy. It will be under radiology, real time, right? And after that, it will be followed by the insertion of a guide wire. It's basically right here into the pelvis and also the ureter, if it's in the ureter. I'm pertaining to the stone. Now, after that, there will be dilation of the urinary tract using a balloon dilator, and it will be caught. The stone will be caught using a grabber, or known as the nephroscope, that will reach the stone. Now, after that, it will be fragmented. It will be broken into pieces using some hydraulic shock, or could be some laser that will also be removed with probably forceps or maybe graspers or maybe a basket, microscopic or small basket that can be accommodated inside the urinary tract. Now, this is another procedure that can be done together with the ESWL. And this is a procedure that also has some risk. And one of those will be bleeding because of fragmentation of those stones once they get past, or maybe there is some erosion into a particular portion of the urinary tract. It can cause that bleeding. Also, infection and urine leakage. And so the care really is continuous. It doesn't stop when we send our patient to the procedure room. Once they get back, the care continues, and you really need to pay attention to the possible complications once they return. Now, another procedure that we'll be expecting is the ureteroscopy. So what is that? This is a procedure that will also require NPO status for both liquids and solids. It will require 6 to 8 hours, and also signing of the consent. And this is a procedure that is most suitable for stones in the low ureter and also the mid ureter. And this is a diagnostic test that will involve the use of a flexible, also a rigid grasper, or the ureteroscopes, and this is going to be paired with the baskets or the graspers. Now, after that, it will also involve the use of fragmentation tools. It will break down the stools using an electrohydraulic instrumentation, and also ultrasonic device or maybe laser device that will break the stones into smaller pieces. And after that, there is going to be an insertion of a stent. And this is the kind of procedure that was planned to be done on my elderly woman, the patient that I took care of before. She was going to have that stent placement only, but not really the ureteroscopy. And so they're going to do that only, but apparently she had a sepsis. Now, Another testing that we're going to expect is the open surgical procedures rather. There are about 5 of them. And so first is the pyelolithotomy, which is the surgical removal of the stone from the kidney pelvis. And we also have the nephrolithotomy, which is a surgical incision is done into the kidney to remove a stone. And we also have nephrectomy, which is pretty much the removal of the entire kidney when it is severely damaged. Or it could be a partial nephrectomy if a part of that kidney is still salvageable. Now, another is the ureterolithotomy, wherein there is removal of the stone from the ureter. Of course, it will involve some incisions. And the last one we have is the cystolithotomy, which is the stone removal from the bladder. So I've never had a patient with a stone in the bladder. Most of my patients have their stones in the ureter or in the pelvis. And since these are surgical procedures, like invasive procedures, really going to require incisions, the patient will be sent to the OR, and this is going to require them NPO for about 8 hours at least for both solids and liquids, and make sure that they have signed the consent, of course. And part of the care in the post-op phase, we are going to continue monitoring their vital signs. It's very important because if in case there is a appearance of urinary tract infection, this could be detected by the elevation of the temperature. It could be tachycardia or maybe subtle changes in the blood pressure. That is why I'm very anal about vital signs monitoring. I'm really anal about it. I can't deny it. Now, pain management is one of the mainstays. Again, you got to be ready. It's not because the patient is demanding. It is expected that you really need to treat their pain because this is very intense. It's colicky pain. And I hope that you will experience this if you're going to deny the patient about their pain management. You better treat them right. And so you need to be on top in administering the prescriptions, especially those opioids and analgesics. It could be in a form of morphine or could be dilaudid. You got to be on top of your game here. And so same thing with the fluid management. This is very important as we are going to really flush the urinary system of those residual sediments from the different procedures that we talked about. And so we want to make sure that this will be passed down into the urine and again to clear the urinary tract. Now, we are going to expect some bloody tinge in the urine. That's normal, okay? I'm not saying that is normal, but this is an expected finding that you will see blood tinge urine. It will be pinkish. Probably in the first few minutes, it will be somewhat kind of like reddish, like red. And don't be alarmed. This will diminish, and you should be watching if the urine color will not change in the next few hours. It should start to become more pink or lighter when there is hydration. Because if not, if you're not really hydrating your patient, what can happen is that those can form clots inside the urinary system, and there you're going to cause some more complications. We don't want that. So you want to make sure that your patient is encouraged to take in as much as possible orally and also with the IV fluid that we are giving them. Along with that, we're also going to deal with the nausea, vomiting of the patient. It's just not the pain, guys. I mean, when you really take care of a patient with nephrolithiasis, it's no joke. You're going to be in and out of the room because by the time you return with the pain medication, they're going to ask, can I have my anti-nausea medication, please? Can I have my Zofran? Can I have my Phenergan? Can I have my Reglan? So you got to be prepared for all those as needed or PRN medications that were prescribed by the physician because I'm sure you will be giving all those if needed. Yeah. And so after that, we're also going to maintain the wound care of our patient, especially for those that had the surgical procedure. We want to make sure that we are practicing hand hygiene, also careful checking of the dressing, looking into the site if there's any drainage or any bleeding post-op, and also careful application of a sterile dressing each time the dressing is changed. And this will be dependent on the physician's order or the medical provider's order. Now, another is to promote activity. And the reason for that is we are going to allow the patient to ambulate as much as they can, as tolerated, in order to allow the downward movement of those stones and also to cause those sediments to flow into the lower part of the urinary tract. So activity is a key intervention here. Now, another thing that we need to do in the care of a patient with nephrolithiasis is to watch out for the possible complications. Yes, I'm not kidding. Complications can arise in this patient that just had those special procedures. Yep, even the surgical procedure. So what are those complications? One is obstruction. Well, again, it's because of the residual stone fragments. Let's say when a patient had a lithotripsy, those are fragmented into smaller pieces. So when there is some portion of those stones that probably were not pulverized well, it can obstruct into those narrow lumen in the ureter. So it can do that. So probably your patient will need another session, or else it can cause renal failure to your patient. Now, another complication is infection. And the reason for that is because of possible dispersal of the infected stone, especially the struvite stones, and will also be dispersed on the kidney or in the circulation as well. And so another complication here is impairment of the kidney function. So if you're not really communicating those complications to the physician, let's say it's been a while that the patient has been in a whole lot of pain because there is recurrence, there is now reblockage of the ureter because of the residual sediments. If you're not really on top of your game here, this patient can end up with acute renal failure, post-renal type, because of the blockage. And so this will really require another procedure, open up that area in order to allow the passage of smaller stones. Now, there's also perirenal hematoma, and this is the bleeding around the kidney from the ESW or the shock waves, or it could be as a result to the laser treatment. So even the procedures can do a whole lot of complication, and that is why the post-procedure nursing care is very important. You have to be on your game in monitoring the vital signs. Again, don't just routinely do it because it is ordered. You have to keep an eye into the different subtle changes in the heart rate, the blood pressure, the temperature, the respirations. It's very important, guys, I tell you. And also, we need to be up to par in delivering our nursing assessment, even when we're just starting the admission of this patient with the nephrolithiasis. When we are admitting the patient, you gotta do your thorough history taking. If you are the first nurse touching this patient, you gotta focus into their medical history, their family history, their history of dehydration maybe, or immobility, or it could be urinary tract infection, their history of bleeding, maybe medications. Those are the stuff that we need to collect, investigate further. And if you have a hard time collecting the information from the patient, there's another way. Ask the family members, or it could be retrieving old medical records. Maybe the patient has been a frequent flyer. There's probably an available record in the system electronically, because this is going to be the case when you're going to be in the taking the NCLEX. Pretty much everything is available, and so if probably the patient came from another institution, you can also collect that information. Get a authorization from the patient to obtain such records. All right. Now, same thing with the medication. You can obtain that through getting the information to the pharmacist where the patient gets their medication. You can do it. And so another is to monitor the patient for any signs and symptoms of urinary tract infections, because like I said, most of the time, because of the stasis in the urinary flow, this will become a medium of bacterial growth, And again, the manifestations of UTI will be commonly seen in our patient, like chills, it could be fever, or it could be dysuria, difficulty urinating, or let's say there is frequent trips to the bathroom, and the patient will not really fully empty their bladder. I'm not talking about retention, but just frequency because of the irritability in the urinary tract or the urethra. They will have that urge to pee. Now, there's also going to be a need for us to monitor for any signs of obstruction. So we are going to look for frequent small urinations. Frequent, like I'm talking about drops of urine. And then they would stop urinating, they were going to return to their bed, and then 10 minutes later on, they're going to go into the bathroom again because they feel like peeing and nothing really comes out. And so the patient will also have low urinary output. Please take note of that. It's going to be here. No urine output for some patients, but for the majority of these patients, they probably would have scant urinary output because of the obstructing stone. Well, there is no passageway. So what's going to come out if there is a blockage? Nothing. And so anuria, or no output at all, is expected in some patients. Now let's get to move on into controlling the patient's pain. Again, this is the part that you're going to get busy. I'm not talking about oral pain medications. No. Oral pain medications will not work for this patient, to tell you. It's severe, abrupt, colicky pain. The best route for this medication would be IV, dilaudid hydromorphone or morphine or Toradol. If you're going to give them like morphine tablet, no. The patient will have to wait for, let's say, 45 minutes to an hour just to get the therapeutic effect. It works so slow. So your patient would really need pain control at this point. It will not be applicable for this kind of pain. And so for the control of pain, your medications would be probably including non-steroidal anti-inflammatories or the opioids that are IV in form, or it could be with the aid of proper positioning, right? And so you will assist the patient to find a more comfortable position, and you got to ensure that you're reassessing the patient. Let's say, for example, if you are treating the patient with, or have medicated them with Dilaudid, let's say 0.5 milligrams Dilaudid or hydromorphone, or let's say morphine sulfate 5 milligrams IV push, and probably the doctor has ordered to give that medication every hour or every 2 hours for this adult patient. Usually, what we're going to do when we are giving an IV form of narcotic medication is to assess their pain level within 30 minutes. Yes, that's how we are going to assess. Within 30 minutes after the injection, definitely do your reassessment. Don't wait for after an hour, because the an hour evaluation that is intended for the oral form. So there's that difference in the evaluation time after you medicate your patient. Now, another thing is you're going to also administer the antiemetics, and this is to control their nausea, their vomiting. And some of these patients that come into the hospital, they probably had several vomiting at home for probably hours and hours. And think about the electrolytes and fluids that they lost at home. I'm not kidding here. If they probably had experienced the colicky pain at home and probably they are resistant into going to the hospital right away, they probably had vomited for probably 12 hours, 10 hours at home. And so expect that the patient has lost a whole lot of sodium chloride, potassium, and probably expect that your patient will go into metabolic alkalosis at this point. And even so, if their pain probably is much controlled at this point, since they already get admitted to the hospital, you will still hear some complaints from the patient that they're still nauseous or still have that feeling of gonna vomit anytime soon. So you really need to prevent this from occurring again. Okay, and so most of the time when you're gonna take care of this patient, you're gonna be getting standing order if you're lucky with a good doctor. You will be getting a standing order for the PRN meds. So you'll start with the milder form. It could be the Zofran or ondansetron, Q4 hours IV, 4 milligrams. And within an hour, if the patient did not have any relief from the nausea, probably you're going to go with the next step, which is the administration of the Reglan, metoclopramide, right? And could be maybe the patient did not respond, and we have a standing order to administer Phenergan or promethazine IV, and according to the frequency as well, you can give that if the patient did not get any relief from the previous anti-nausea medication. So your evaluation to the different treatments that you have given to the patient is paramount at this time. So like I've said, you're going to be in and out of the room until the patient is much more stable. All right. Now, at this point, when you're going to take care of the patient, maintaining the urine flow is of utmost importance. And how are we going to promote that? Well, we are going to promote intake of oral fluids as the patient tolerates. Because if they're already vomiting or nauseous, of course you're not going to give them water, right? No, of course not. You're only going to give water if they're not nauseous. So, of course, you're going to have another route. If we have an order for IV fluid administration, go ahead and do that according to the prescribed rate. And make sure this is done, because this will really help flush the urinary system. Okay? And since we are flushing the urinary system, you have to keep an eye into the urinary output as well. Not just straining the urine, but also looking into the consistency of the urine. Is it reddish? Is it pink? Is it just kind of normal, yellowish, straw colored? Or is it cloudy already? Yeah, you gotta have to keep an eye on those differences and make sure that you are straining the urine. Every time the patient goes to the bathroom, you have to strain the urine. And if you're too lazy to do it, that's gonna be on you. If you're only going to rely on the nurse aide doing the straining while they're taking for maybe another 20 patients, that's probably going to slow down the care of your patient. So you better do it on your own as well. Okay, so you got to coordinate with your CNA at this point. Now, every time you're going to find any sediments, you're going to collect them, put them in a sterile container, and if there's an order to send those sediments, you're going to have to label properly the container and send it to the lab for analysis. Okay, so again, every time you're going to have to collect the sediments. Now, not just because you're infusing the IV fluid, then your intervention is done. No. If you are delivering IV fluid, or if you're encouraging a lot of fluid intake orally, you have to monitor their output as well. Because if the patient is not putting out that same equal amount, then that simply means that the urine is not passing through distal the blockage. So it's actually being trapped in the upper portion of the urinary tract. Again, it can cause the acute renal failure, which is the post-renal type. Now, ambulation is another one. Like I've said, it will help move the stones through the urinary tract. And another thing is we're going to have to control the infection by administering those antibiotics, also the use of infection control, hand hygiene, and make sure that we are teaching our patient to properly wipe their perineal area. Yes, that's true. There are some elderly people that are not really good in cleaning themselves, so you have to educate them. All right? Even though they're not really going to pay attention, you have to be persistent, make sure that they're going to practice it. And so this will help them quite a lot. I've had so many patients that are very ornery. Okay? They kind of talk back. And of course, you have to stand your ground as a nurse. Another thing is you're going to have to check the patient's vital signs as well. This is a big deal. Like I've said, your patient can possibly go into sepsis. Those subtle changes in the vital signs, the blood pressure, the heart rate, the temperature, this will really help you. So don't neglect about the subtle changes, the trends of the vital signs, especially the temperature. Now, also check on the, did I miss something? Yeah, I think I missed something about the urine. Yes, I already said it. Okay, let's move on. Now, part of the care is to promote education to our patient, not just the patient, but their spouse or maybe their family members, their children, or maybe the caregiver. That's part of the care. And so this is going to, the first part of education here will focus more on the recovery after they had a surgical intervention. And so once permitted already, once they are allowed to take in oral fluids, then encourage drinking of fluids in order to pass the stone fragments. Okay, that's one thing. Or it could be the administration of the IV fluids. Some of these IV fluid prescriptions would be 100 and 150 mLs per hour, or it could be 100 mLs per hour. It varies. And one thing here that you need to be careful, especially if you are dealing with an older person, I'm talking about 60 above, or let's say those people that may have a history of congestive heart failure. There you go. That is something that you need to keep an eye on. If you have an order to deliver IV fluid at 150 mLs per hour or 125 mLs per hour, or let's say 100 mLs per hour, this is probably going to aggravate their pre-existing congestive heart failure. So you got to pay attention into the patient's responses once you initiate the IV fluid rate, because this can complicate things all the more. And you got to notify the doctor about it because they probably had missed this part about the patient's history. Now, pain management is really important. You're going to have to educate the patient about the need for pain relief medication, especially for the colicky pain during the stone passage. Now, another is to educate about the patient on the hematuria, inform that some blood in the urine is going to be expected in this patient for several weeks. Okay, so that is something that you need to emphasize, that they are going to expect some residual tinge of blood in the urine. But of course, you have to really tell them that if there is a sudden change in the color of the urine, maybe from a pink tinge already for maybe 3 days, and then all of a sudden the color of the urine turned into reddish bright, well, that's not expected anymore. That's a huge change. So they better have to call their medical provider for a possible immediate treatment. All right. Now we're going to talk about frequent activity, and that will be pertaining to the ambulation. And this is something that we need to encourage to allow the passage of the stone fragments into the lower portion of the urinary tract. And also, they need to collect their stones, the precious stones, the jewels. This is something that they need to be doing. And at home, what they can use is the coffee filter, because most of these people are coffee drinker, probably. Yes, most of the Americans are coffee drinker. No joke about that. What they can do is they're going to be able to use the coffee filter to strain the urine and also to collect those stones for analysis. But this is something that will be applicable if there was no previous study yet. Okay? Again, this is subject to the prior study. If there was already a study, then there's no need for them to collect another set of stones. That would be dumb. So is only applicable if there was no prior collection for stone analysis. Now, another thing is to educate the patient on the taking of the medication called the alpha adrenergic blockers. And the reason for that is to allow dilation of the ureter. Imagine that. It's just not going to cause dilation of the blood vessels, but it will actually cause dilation of the ureter, and it will allow the passage of the stone. How amazing, right? But it's just that because it's going to work for somebody that it will be available, that it should be done on everyone. No, of course. Everyone has different responses to medication. So it might be effective to one patient, but will not, or it will be contraindicated to the next. Please take note of that. Now, we're going to talk about the prevention of the recurrent stone formation. And so if we have a patient that has the calcium oxalate stones, and so our focus here is to alkalinize the urine. So what we're going to do here, we are going to we're going to teach them how to do the testing of their urine by using those strip to test their pH, and also to take their medication. Okay, an example here is Actually, that should not be allopurinol. Correct that one. So scratch that one. Since we are talking about the calcium oxalate, what will be done here is to have them have a restricted calcium, uh, phosphorus, and also a low sodium diet. Okay. And also, we're going to explain the purpose of the thiazide diuretic to reduce the urine calcium. So it's not allopurinol, but the thiazide diuretic. Now, what we're going to also expect here, yeah, I've mixed up the two here. So this one right here, diet, reduce intake of urine. This is for the uric acid. So that needs to be scratched. And so for the uric acid stones, our goal here is to alkalinize the urine as well. We're going to have to teach the patient in the different methods of alkalinizing urine. And one of those is intake of some foods, especially also testing the pH of the urine. And here we go. We are going to the doctor will prescribe them the intake of the allopurinol to lower the uric acid. Okay, and this is for the uric acid type of stone, not this calcium oxalate. Now, for the diet change here for this patient, we are going to reduce the intake of the purine-rich foods like red meat or fish, poultry, and also legumes. So those are the known food products or items that can cause what do you call this? No. We're going to reduce the intake of the pure-rich foods like, yeah, the red meat, the fish, the poultry, and those legume type of foods. Now, if we have a patient that may have the struvite, infected struvite stones, we're going to have to teach them about the different manifestations of the urinary tract infection and also teach them how to use the dipsticks for detecting the infection. And also, we're going to have to teach him to avoid long periods of inactivity. Because if that's going to happen, they're just sedentary, they're sitting on the chair or let's say laying on the sofa 10 hours a day. This is going to cause the sluggish flow of the urine. Okay, we want to make sure that there is enhanced renal drainage and also flushing of those products. Now, with the case of the cystine stones, we are going to alkalinize the urine, of course, with the use of the sodium bicarbonate. This is going to be prescribed, and this is going to allow the solubility of the cystine type of stone. And they're also going to be taught about testing their urine pH. And we want to make sure that they are taught on the use of the penicillamine, which is the medication that will lower the cystine, or it will also dissolve the stones with the thiol derivatives. So again, that is the penicillamine D or the D-penicillamine. This will dissolve the stone. And also make sure that you are going to educate them for consistent use of the medication in order to properly reduce the amount of this type of stone, especially the cystine stone. Now, part of the care here is to include all the teachings, and that will include a fluid intake, of course. It's highly recommended. If there is no restriction, no contraindication, then their fluid intake should be increased. But for those people that may have problems in their cardio function, like heart failure, that will be challenging. So fluid intake increase would not be suitable for them. And so the doctor will have to prescribe them a different plan of care. Okay. Now, part of the care for the regular, just those people without any concerns of CHF, the fluid intake would be enough in order to dilute the urine and also reduce stone formation. And their diet will be low in sugar. Why? What is the rationale that in the general population, for those people with a different type of stones, why sugar should be lessened or why is it restricted? And why is it that animal proteins will also be reduced? And also, we are encouraging high fiber. So again, diet low in sugar and high in animal proteins. Why? Because with a sugar, it can actually reduce the calcium excretion because with the sugary drinks, let's say, like items, food items that are quite sugary, it will increase urinary calcium excretion. And so it will increase their risk of developing calcium stone formation. Okay. Caffeine, cola, which can actually displace the calcium from the bone. There is bone resorption. This will displace those calcium ions from the bone, and they are going to be pulled out into the blood, and this will eventually be uh, trapped somewhere in the kidney. And so that is why sweet or sugary drinks are not supposed to be in their diet. Now, another thing is that the medication, with the use of the sodium bicarbonate, we are going to um, alkalinize those acidic urine. So it really depends. So this sodium bicarbonate probably will not be effective for those other types of stone. And so I'm just emphasizing with this particular type. And so for those that are supposed to alkalinize their urine, then possibly there is a prescription to take sodium bicarbonate and also potassium citrate. This will be needed to change the pH of their urine. All right. Now, moving into monitoring the urine pH. This is going to be important. They need to record their pH in their logbook. And so they can determine, because the diets that are high in that could probably alkalinize would really cause some problems. They will be at risk of developing those type of stones as well. Now, another is the follow-up, and also, hang on a sec, follow-up and making sure that they're going to show up for their appointment and making sure that they are taking their prescriptions on the scheduled time in order to lyse those stones. They are going to be compliant, supposedly. And so this is something that you need to reinforce and to remind the patient in order that there going to be some resolution for their chronic disorder. Like I've said, this is a recurring problem. Okay, they could come back with the same type of stones if they are not compliant with the treatment plan. And so, of course, we are going to deal with the Q&A portion here. So the first case that we have is about kidney stone. This is a patient with urolithiasis and a history of recurrent urinary tract infections. Is likely to have which type of urinary stones? Again, the question says, a patient with a urolithiasis and a history of recurrent urinary tract infection is likely to have which type of urinary stones? Is it A, calcium oxalate? Is it B, uric acid? C, struvite? Or D, cystine? Take your pick. All right, your time is up. So we'll reveal the answer in a few. And so let's go through the first set of answer here. Letter A, calcium oxalate. Well, this type of stone result from increased calcium intake and those conditions that can raise the serum calcium level. And our question here is basically a patient with a recurrent urinary tract infection likely to have which type of urinary stones. Remember what type of stone they are if the patient has recurring UTI. I've mentioned this. And so calcium oxalate is not associated with this kind of scenario. We're going to eliminate that. What about letter B? Letter B, uric acid. The uric acid stones, as a review, they are going to develop in individuals with gout, not with urinary tract infections. Again, this is a distractor. Eliminate the uric acid. Okay. What about the struvite, the staghorn type of stone? What do you think? Do you think is this the answer? Well, as I've said, the struvite stones are typically going to form in an alkaline urine with high ammonia content. And this is something that is mostly associated with the urinary tract infections. Yep, we have that as the answer. But we still have letter D, cystine. What is this kind of stone? So this is a stone that are rare, but they can occur in patients with a genetic disorder that can reduce the renal absorption of the amino acid cystine. And of course, this is not associated with a urinary tract infection. Again, another distractor. Eliminate that. So we are left off with letter C. All right? Easy peasy question. That'd be nice if that you can be asked by just an objective, right? Probably you're gonna finish the exam within an hour. Now, for the test taking strategies, I always want to share with you your test taking strategies is to focus on the clinical scenario. Again, go back into the information in the scenario. This is very crucial. And again, our clue here is the recurrent urinary tract infection. Okay? It didn't say how many times in a year, but it said recurrent. So it means that maybe the patient has been having this several times. Who knows how many? But again, recurrence is your keyword here. And so this is really going to point out towards the struvite stones, like I have said. Now, another clue here is to use your knowledge. If you have really done your diligent study, reviewing this content that I shared with you, going back into your textbook, into your notes, you really have to operate your knowledge here, use them. You have to remember the typical conditions that are associated with the different types of stones. I've created a table for you in order that you can get it. So hopefully you will be getting a correct answer. Now, another is the elimination of the distractors. You're going to have to eliminate those items that are obviously wrong to narrow down your choices, and you need to focus on the most relevant clinical clues in the situation. All right, so I hope that you were able to get that correctly. Let's proceed with the next one. Scenario assess. A nurse is assessing a patient who reports intense pain in the left lower back area, along with nausea, vomiting, and agitation. The patient is pale and sweating. The vital signs recorded are blood pressure of 145/85 mmHg, pulse of 112 beats per minute, respiratory rate of 30 breaths per minute, and temperature 97 degrees Fahrenheit. Based on these observations, which symptom most strongly suggests the presence of kidney stones? Is it A, a history of mild flu-like symptoms, or is it B, vomiting with a coffee ground appearance, or is it C, pain spreading to the left upper abdomen, or D, urine that is dark and produced in small amounts? Okay, take your pick. All right, time is up. Now let's go back into the situation here. It said a nurse is assessing a patient who reports intense pain in the left lower back area. Remember, it starts with a flank pain, right? That's just like what I've said. Left lower back area, the flank area, along with the nausea, the vomiting, agitation. Of course, I'll get agitated if I have that kind of pain. The patient is pale and sweating. That is part of a sympathetic nervous system response. And the vital signs are blood pressure of 145/85 mmHg. The patient is in pain, of course. That's another response to sympathetic SNS stimulation. The pulse is 112, above the normal. That's already tachycardic. And the respiratory rate of 30 breaths per minute, way above. Our cutoff is 20 cycles per minute. That is way fast. And the temperature of 97 degrees Fahrenheit, normal. Based on this observations, which symptom most strongly suggests the presence of kidney stone? So let's go through each item. For letter A, A history of mild flu-like symptoms. What do you think? Did we talk about that earlier? Hmm. So if you're gonna pick that as an answer, well, a mild flu-like type of symptoms like low-grade fever, body aches, could be fatigue, they are going to be non-specific and can be associated with other problems. Let's say pyelonephritis, right? Or could be viral infections, but it's not specific to the renal calculi. All right, so we are going to eliminate that. We are not sure about that. Now, what about letter B? Vomiting with coffee ground appearance. So what do you think about that answer? Would that be a possible answer? So if you're going to say, maybe the vomiting was so severe that it caused some erosion into the gastric lining, no, that's not going to be possible for a kidney stone. The vomiting that is associated with this, it's coffee ground appearance. This is significant. However, this is not going to be associated with the kidney stone because this is often associated with a stomach or an ulcer in the upper part of the GI tract, especially the small intestine. Okay, GI bleeding. All right. So this is not gonna be associated with the kidney stone. We're gonna eliminate that. This is a GI manifestation associated with peptic ulcer disease, PUD. Could be a duodenal ulcer, could be the gastric ulcer. Okay. Have you seen a coffee ground vomitus yourself when you were back in nursing school? Lucky you if you're able to, if you have seen that, because that would really linger in your mind, even if you're nurses. Yeah, it would really nice if you had experienced that for your patient because you will really appreciate the different changes in the gastric contents. And so again, this is not associated with the kidney stone. Let's talk about letter C, pain spreading to the left upper abdomen. So what did I say about the radiation of the pain earlier? Well, with this pattern, the pain is spreading to the left upper abdomen. Left upper abdomen, that kind of points out to the spleen area or could be the pancreas. So it's not really going to be associated with a renal colic. Yeah. So for a kidney stone pain, this will radiate, but it typically will start from the flank area, okay, the backside, into the lower portion of the abdomen. Again, from the flank area. Let me write that down slowly. I'm just using my mouse. Flank area. Then it will radiate to the lower abdomen. And eventually it will, the radiation of the pain will reach the groin. So it goes the pattern of the movement of the stone from the upper to the lower part of the urinary tract. So again, flank area to the lower abdomen, then to the groin. So it's like a flow of an electricity kind of sensation that's very sudden, so intense. It's just like a piercing kind of sensation that kind of radiates down to the groin. So that's basically the characteristic type of pain. And so we are eliminating letter C because it's saying left upper abdomen. Exactly opposite. Now for letter D, urine that is dark and produced in small amounts. What do you think about that? Well, of course, we don't have any other options, right? But this letter. So this is the best way to actually answer. Do it by elimination. Think about the different answers first. So you don't have any other option but letter D, which is actually the perfect choice for this test question. And why it is dark? Well, because of the hematuria and also produced in small amounts, scant amounts. So what do you think about that? It is scant because the flow of the urine in that particular uh, urinary tract. Let's say this is the ureter, and this is the bladder over here, and then the ureter on the right side. So for example, if the stone is lodged in the middle part of the ureter, well, of course, you're only going to expect urinary, or the collection of urine will be dependent only on the right side, right? Maybe it's partially blocked over here, so you will still get some urine output or collection of urine in the bladder, and there will be tinge of blood if there's erosion. But typically, when there is that significant obstruction, it will definitely affect the volume of the urine. There will be some oliguria, and in some patients, there will be anuria, no output at all. Again, that is because of the obstruction. And what happens if there's obstruction in this section? It will cause the urine to flow back into the renal pelvis and into the urine. It will cause swelling into the renal parenchyma, causing renal failure, post-renal type. Okay? Now, let me erase that. So again, we are left up with just one answer, letter D. The color is dark, produced in small amounts. This is an indicator of the kidney stone. Another is that with a severe flank pain, of course, in the lower back. It's pretty much like the classic manifestations, really, that I have discussed. So there you go. We got this one correctly. Now, for the test-taking strategy here, we again have to eliminate those options that do not directly correlate with the common symptoms that we have studied. And we again will narrow our option to the most relevant option based on the clinical presentation in the scenario. And also we're going to have to make sure we have to consider all the data that's presented in the scenario, make sure that we are evaluating everything, all the subjective and objective cues, the lab findings, and make sure that we're going to relate to the most common conditions, right? Moving into the next item here. While attending to a male patient diagnosed with acute renal failure, the nurse anticipates the need to modify the dosage or timing of administration for specific medications. We are switching here to a different case, acute renal failure, guys. So which of the following medications would not necessitate such modification? Again, reading back the question. While attending to a male patient diagnosed with acute renal failure, the nurse anticipates the need to modify the dosage or timing of administration for a specific medication. Now, which of the following medications would not necessitate such modification? Is it A, vancomycin, which is an antibiotic, a glycopeptide antibiotic, very powerful antibiotic. We have B, picarcillins disodium. We have C, cyclosporin, which is an immunosuppressant. And D, acetaminophen. Take your pick. All right, your time is up. So let's go through the answers here, the options. What is going on with letter A, vancomycin? Do you think that this would require some change in the dose for the vancomycin? Let's go back to the question. Which of the following medications would not necessitate? Take a look into that clue. Would not necessitate such modification. So basically, we're looking for that medication that is part of the treatment plan that would not really be a concern for this particular patient. We're not going to worry about it. It's not going to harm the patient that has already a diagnosis with acute renal failure. So let's go first with the vancomycin. What do you think about vancomycin? Well, this is a powerful antibiotic, and this is going to be eliminated through the kidneys. Okay? Renal excretion. This is the main route of getting rid of the vancomycin through the kidneys. And with patients that has the acute renal failure, this drug can readily accumulate in the bloodstream. It can become toxic if we are not going to follow the dose properly. And this is something that is going to be collaborated by the physician, the pharmacist, the nurse. Okay. All eyes are on going to look into this patient's laboratory and also the medication. Because if there is a reduction in the glomerular filtration rate, or let's say the creatinine clearance, or let's say there's an elevation of the creatinine level or the BUN and some other key manifestations of renal failure, then definitely if the patient has some kind of infection that will require treatment with vancomycin, this will need to be adjusted. Okay, I'm talking about the dose. This will be adjusted by the pharmacist, and there will be some laboratory checks periodically to check for the peak, the trough, which I'm talking about here. Like when I'm talking about the peak, the highest level of the vancomycin dose and also the lowest level of the medication. And so let's say, for example, if we are expecting a test called peak vancomycin level. So this is something that will be done after you had administered the medication. Let's say after an hour or 2 hours of vancomycin infusion, the peak will be drawn several minutes after the infusion has been completed. And so it will measure the level of that highest level of the medication. So if the peak exceeds the expected range, then that is already considered toxic. Now, for example, if we are checking for the trough, which is basically the lowest level of this medication. So for example, this is done as a blood draw, let's say about 30 minutes or an hour before we administer the vancomycin IV. And so the phlebotomist will come in, we'll check with you. Hey, I'm just letting you know, I'm here to get some blood sample of your patient. I'm here for the trough level of the vancomycin. And so the reason that we are wanting to know the trough level is to see if the medication in the bloodstream before you give the next dose of the vancomycin is within the acceptable range, meaning it is in the safe range. It's not too low and it's not high for the recommended trough level, because if it's too high, even though you haven't given the medication yet, then probably the dose is way too much for this patient. Or let's say the trough is very low. That simply means that the dose probably is not enough for this patient. So that is why we need to be guided by these two different levels. Okay, so aside from the peak and the trough, we also have to check on the other kidney studies or the renal function studies, the GFR, the creatinine clearance, and also the creatinine and also the BUN. All right. So again, for the renal patient, we definitely need to expect some modification of the dose. So that is why we are gonna eliminate vancomycin, because this patient has acute renal failure, definitely needs some adjustment of the antibiotic dose. Now let's talk about letter B, ticarcillin disodium. What is this? This is an anti-infective, which is actually a penicillin, which is a classification of antibiotic. And this is going to be excreted the same route, renal. Okay? And so if a patient has a pre-existing renal problem, well, what do you expect? There will be a possible accumulation of the medication in the bloodstream because the kidneys are not able to excrete the medication properly. It's going to become a toxic substance. And so, again, it's going to require adjustment of the dosage and also the timing, the frequency, how many times a day it will be given. Maybe instead of giving it every 8 hours, maybe it's going to be every 12 hours now. And also the dose will be adjusted. So it just depends on the different studies that will be resulted. Okay. Now, what about cyclosporin? So we are eliminating B. All right. What about C? Cyclosporin. What is cyclosporin? This is an immunosuppressant drug that can be metabolized by the liver. So it can be metabolized by the liver. Remember, guys, that the liver can lessen the amount of the medication. It will, at some degree, it will bring about a small portion of that medication to be ineffective. That's what we call as metabolism, okay? So it will decrease the amount of that medication, all right? And so it can also affect the kidneys. It is going to be nephrotoxic as well. So you got to be careful when administering the cyclosporin in a patient with an acute renal failure. And this is going to be dependent upon again, the renal function studies and also the adjustment of the dose by the pharmacist, the PharmD, the doctor of pharmacy, and also with a physician. They're going to collaborate in order to prescribe a much safer dose. Now, talking about the acetaminophen here, which is basically the Tylenol, acetaminophen. All right, so this is a drug that is primarily metabolized by the liver, but not metabolized by the kidneys. So therefore, in acute renal failure, there's no need really to adjust the dosage of this medication. Like I've said, it is metabolized by the liver, and it doesn't really cause a impairment into the kidney function. It doesn't impact the kidney function. All right. So I hope that you were able to get my rationale here. And so we'll talk about your testing strategies. So again, what we need to do in this item is to understand the drug metabolism and excretion. So this is fundamentals of pharmacology. And I teach pharmacology as well. And I like to teach this portion because it's quite interesting. And so you have to go back into the pharmacokinetics, pharmacodynamics. Quite important. Don't neglect those. And so here, for the teaching strat, we need to differentiate the different drugs and their mechanisms and how they are going to be metabolized by the liver, and also maybe excretion route. Is this a drug that is primarily excreted by the kidneys, or is it a drug that is excreted by the GI tract into the feces? Or is this a medication that could potentially cross the breast milk, or is it something that can potentially cross the placenta, affecting the fetus? So you really need to pay attention to the different routes of the routes of excretion, okay? The metabolism. You have to review those. And around this time, we have identified that really the acetaminophen is primarily metabolized by the liver. It doesn't really affect the kidney function. So it's safe to take this medication for this patient. Now, another teaching strat, or the testing strategy rather, is to recognize the potential toxicity of the kidney of certain medications. Like I've said, like these, vancomycin, antibiotics. Yes. Okay. So let's just tackle this. So most of the time, those antibiotics like vancomycin, cephalosporin, cefepime, ceftriaxone, ceftazidime, penicillins, these are primarily excreted via kidneys. So what you're gonna look for here is the kidney function. Make sure that a patient's kidney function is intact. All right. Now, for those medications that are metabolized by the liver, let's say like acetaminophen, the statins, especially the simvastatin, those statin medications, the fenofibrates, the fibrase, ezetimibe, those medications are metabolized in the liver. Okay, so you're gonna lean towards the liver function test, like the AST, ALT, SGPT, or SGOT if you're referring the old terms, or it could be the other enzymes, or it could be the other testing like alkaline phosphatase and so forth. Now let's get moving here before I get trapped into this situation. Now, Another example, another testing here is a nurse attending to a patient diagnosed with acute renal failure who also presents with elevated blood pressure levels. The nurse wants to identify the primary factor contributing to hypertension in cases of acute renal failure. What is the most prevalent element leading to hypertension in such instances? Okay, let me read that question back. The nurse is attending to a patient diagnosed with acute renal failure, or AKI, who also presents with elevated blood pressure. The nurse wants to identify the primary factor contributing to hypertension in cases of acute renal failure. So, what is the most prevalent element leading to the hypertension in such instances? Is it A, decreased levels of red blood cells? Is it B, excessive body fluid volume? Or is it C, insufficient body fluid volume? Or is it D, accumulation of fluid in the lungs? Right? Make up your mind. Take a pick. All right, time is up. Now let's go back into the situation again. I always like to read back. So, our patient has an ARF or AKI with hypertension, and she wants or he wants to, or the nurse wants to identify the primary cause of the high blood pressure. Okay? I always like to do that. When I'm answering the test questions, I have to write them down. I'm not quite sure if you're still allowed in the computer base. I don't know if they're going to give you some pen and paper or pencil and paper to write down your ideas. I'm not quite sure if it's still allowed to do that right now. But I remember back in 2005, we were provided some pencil and paper to jot our thoughts down. And so you can do that as well if you're allowed. So you can narrow down the different scenarios. And so, what is the most prevalent element leading to the hypertension in such instances? Is it A, decreased level of the red blood cells? Does it do that? Or is it the excess fluid volume? Or is it low fluid volume? Or is it the accumulation of fluid in the lungs, which is basically pulmonary edema, right? So let's go through the options here. Letter A, while a decrease in the red blood cells, actually, this is anemia. Let me just write that down. Anemia. This can actually occur in chronic renal failure, okay, but not in acute. Remember about the function of the kidney, which is basically to produce the hormone erythropoietin. If you did not watch my first video, you got to go back to that one. This is the necessary hormone that is supposed to be secreted by the kidney in the normally functioning state, erythropoietin. Well, what it does, if the body senses that there is now some form of anemia, it will trigger the release of the kidney the kidneys will release the erythropoietin to target the bone marrow, especially the red bone marrow. And the reason to do that is to allow production of the red blood cells, okay? To increase red blood cells, RBC. However, in acute renal failure, there's not really a significant drop of the red blood cells because it's acute, right? It's a sudden impairment of the kidney. So the production of the erythropoietin at this time is not impaired yet. So you're not going to expect anemia in acute renal failure. However, anemia is common in CKD, chronic kidney disease or chronic renal failure. So we are not going to expect the low hemoglobin or low anemia in this scenario. Okay, scratch that one. Now moving into the next option, which is letter B. excessive body fluid volume. Remember, guys, about the different phases of the acute renal failure. We have the oliguric, second followed by the diuretic, and then we have the recovery phase or the convalescent phase. So excessive body fluid volume, this is overloaded body. So the patient here is not able to excrete the fluids that are supposed to be urinated, also with the toxic products. So the patient will end up with hypertension. Remember, there is that data here. The patient is hypertensive, right? And so at this point, the kidneys here basically has an abrupt ability to excrete the fluid along with the byproducts of protein metabolism. So again, our problem basically here is fluid volume overload. Let me just clear my screen. Okay. So I'm just going to put FLD, stand for fluid volume overload. There is such an excess. So where does this fluid gonna go to? The patient will become hypertensive. At some point, this will also overwhelm the patient's lungs. And for those patients that have pre-existing congestive heart failure, it will aggravate the congestive heart failure as well. And let's take a look into, so this is a possible good answer. Letter A is scratched. Letter C, we'll find out. Insufficient body fluid volume. Remember that we are in the acute renal failure, hypertension. Well, the oliguric phase is characterized by fluid overload. So we're going to scratch this, remove that. This is going to be found in a patient in the diuretic phase, not in the oliguric phase. So this is diuretic phase of acute renal failure. Diuretic phase. The other one is oliguric phase. And then lastly, we have, this is X, this is check, this is X. Accumulation of fluid in the lungs. So it said here, what is the most prevalent element leading to the hypertension? Is the pulmonary edema causing the hypertension? No. Actually, the pulmonary edema is just one of the complications of the fluid volume excess. So eliminate that one as well. So we are only left with the vitamin B, option B rather. I'm thinking about the vitamin B right now. What the heck? And so, yeah, this is how you're going to answer your test question. And for the test taking strategy, again, we are going to go back into the pathophysiology. And the reason that I made those tables for you when I was teaching that part in acute renal failure, I was actually trying to simplify things. I wasn't even using those pathophysiology with the long arrows at different lines, different levels, because that can become too confusing. So that's what I did. I made it into tables with some explanations. It's actually making them much more simplified. And I have the reasoning there why they're feeling this kind of symptom, and you have there the reasoning why this patient is experiencing those manifestations. So you go back into those notes that I presented. Now, again, focus on the pathophysiology. And again, there is a problem with the excretion of the fluids by the kidney. Then they're going to end up with the overload during the oliguric phase. However, moving forward, if we're going to go away from the scenario, from the oliguric phase, the patient will go into the diuretic phase wherein it's going to be a life-threatening issue also because the body will be depleted of the body fluids. Dehydration, of course, can happen. Now, let's get into the next strategy here. We're going to have to eliminate those irrelevant options. For example, letter A. It doesn't really cause anemia because this is acute renal failure. It also doesn't do a insufficient body fluid volume because the patient is overloaded. So eliminate those one right away. So if you're like questioning about letter D, I'm not quite so sure about the accumulation of fluid in the lungs. But again, think about the pulmonary edema, which is only going to be a complication to the fluid volume overload. Okay, it doesn't cause hypertension, right? Let's move on to the next. The nurse is monitoring a post-op patient 6 hours after cholecystectomy who has an indwelling urinary catheter. So let me go back here. The nurse is monitoring a post-op patient 6 hours after a cholecystectomy who is an indwelling catheter. And initially there was no urine output. And now only 100 mLs of urine has been collected with no apparent blockage. What should the nurse's primary action be in this situation? Is it letter A, performing irrigation of the urinary catheter with sterile saline or water? Or is it B, administer a 400 ml bolus of isotonic saline solution? Or is it C, evaluate the patient's circulatory status and vital signs? Or D, inform the surgical team? All right. Again, going back to the scenario, you're monitoring a post-op client 6 hours after a cholecystectomy, removal of the gallbladder. So they just come back 6 hours ago. You're the nurse assigned. And then when you are looking into their catheter drainage, there was no output. Well, 6 hours, no output? Well, that's concerning. Your patient should be putting out urine even during the first 2 hours. So 6 hours, that's way too long to get this observation. This is kind of dumb. Yeah, I would say dumb, because you should have already captured this during the first 2 hours, not after 6 hours. And so now that you notice that there is now a bit of urine output, 100 ml, that has been collected. Again, 100 ml in a 6 hour period. So what is that? That is very significant. Okay, so if we are to calculate that, okay, so that's basically 16 mLs per hour. That is oliguria, right? That is low. If you're going to calculate that, just basing that 100 mLs for the entire 6 hours, that's oliguria. But just the way this situation has been built, it's dumb. I would say if I am really the real nurse, this is dumb, because this should have been already resolved even during the first 2-3 hours already. But we'll get this question as it is. Okay, maybe the nurse has been taking care of 50 patients. Just kidding. And so we're going to have to really go through here with answers. What about letter A? Perform irrigation of the urinary catheter with sterile saline or water. Well, go back into the situation. It said with no apparent blockage. And if you had answered letter A, perform irrigation of the urinary catheter with a sterile saline or water, this is something that actually would require a doctor's order to flush the urinary catheter. You're not supposed to do it independently without an order, because when you are flushing the urinary catheter, what you're actually doing here is you are pulling the urinary catheter from the drainage system. So it's no longer a closed drainage system, because a regular Foley catheter only has 2 ports. One for the installation of the air to inflate the balloon, and the other one is the port where you're going to connect the pre-connected tubing to the urinary bag. So if you are doing a flush here, as I'm just imagining right now, you're actually pulling one of the tubes here in order that you can flush saline or sterile water into the urinary bladder. No. You're not supposed to break the integrity of the closed drainage system, not even. You're only going to do this when there is a, what do you call this, expected bladder irrigation, right? That you're going to do a flushing. But in some instances, probably that there is probably a blockage, then you would really need to get an order to flush the urinary catheter. But this is not a routine practice. This is something that should not be done. Okay? I would eliminate that one right away. And in the current practice, we don't normally use sterile water. We use normal saline. Okay? Not sterile water, because it doesn't have the same tonicity with the body tissues and the fluids. It can cause transfer of the sterile water into the body tissues because the sterile water is hypotonic solution, whereas the saline solution is isotonic. It doesn't really cause movement of the fluid from the outside of the tissue into the cellular compartment. So you have to keep in mind about that kind of tonicity, especially in flushing. We don't normally use sterile water. So cross that out. I'm doubtful about this intervention. Letter B, administer a 400 ml bolus of isotonic solution. And again, when you are giving bolus IV fluid, this is dependent on the doctor's prescription. Just don't administer it without prescription. Okay? So if it's in such a case, let's say that this has been ordered. When you are administering a bolus of normal saline, it is not really appropriate without evaluating first the patient's circulatory status. So this is like you're jumping into the gun without assessing the patient first. Whereas, so we're going to eliminate that. Okay, letter C, evaluate the patient's circulatory status and vital signs. Seems like this is what we needed, right? And so, let me go back. I'm not done with B yet. So the bolus is only intended in a case wherein there is a case of hypovolemia. The patient might be depleted of circulating blood volume, let's say just dehydrated. And so we need to replenish that fluid, or so maybe there is an order to do a renal challenge wherein we're going to give a small volume of fluid rapidly given in order to see if the kidneys will respond. And so this is definitely what a kidney challenge is. But again, we really need to investigate first before administering the bolus. So letter C, let's take a look. Evaluate the patient's circulatory status and vital signs. Looks like this is the choice, because when we are worried about the low urine output after the surgery, we don't know what happened, right? There was no information if there was some sort of significant blood loss, something like that. We don't know. It's not provided in our scenario. And so this option would really allow us nurses to investigate further to find out if there is a problem with their circulation status or if there is hypotension. That is why we have to check first the vital signs. And we need to also look for those signs of shock. Tachycardia could be a blood pressure that is starting to go downhill a little bit. Signs of shock. Take a look into the patient's tissue perfusion, the cap refill, the oxygenation. Look into the color of the skin, the what do you call this? The moisture of the patient's mouth. What else? The skin turgor. You have to check for the skin turgor, to check for the elasticity. If there is dryness, if the skin would not go back to its original position. So these are things that you need to do first before involving yourself into giving bolus. All right. So I would choose this as my first priority nursing action. What about letter D? Inform the surgical team. Another intervention that's just jumping into the gun. And so this is something that is important though, but should not be the nurse's primary concern at this situation, okay? This is going to be done only if our patient has significant blood loss or something like that, and this has been coordinated by the medical provider as well, that the patient is bleeding out possibly. So this will take place later on after we had done our task to do the proper assessment. Okay, so that's how we're going to answer the test question. Now, for the test taking skill, we need to first assess for the urgency. We want to make sure that we are determining the situation that would require immediate action. And also, there is still time to gather more information. Are we in a case wherein the patient is dying? No, it didn't say that. Is the patient's airway or breathing compromised right now? No, we don't have that information. And so, with that, again, it will involve much more investigation, and definitely we need to make sure, dig deeper into the assessment. Why the patient is having oliguria. Now, another test-taking strategy here is to remove those distractors, eliminate incorrect options. We have to take out those options that do not address the immediate concern or can potentially harm the patient. So in this case, it is option A and B that can be eliminated because they focus on the interventions without first assessing the patient's condition. Readily eliminate that. Okay, unless there is something about ABC's compromise. We don't have that information either. So next strategy here is identify the primary and secondary factors in the situation. So we need to distinguish between the primary causes and also the complication. And of course, we don't really have that in this scenario. I mean, yeah, our goal here is to really identify why the patient is having oliguria. And again, oliguria is a product of not having enough fluid in the vascular system. Okay, that's it. Now moving into the next question, which is the nurse is attending to a patient with diabetes mellitus and undergoing hemodialysis for renal failure. What dietary advice would be most suitable for this patient during the intervals between dialysis sessions? Let me read that back. The nurse is attending to a patient with a diabetes mellitus and undergoing hemodialysis for renal failure. What dietary advice would be most suitable for this patient during the intervals between dialysis session? Is it A, suggesting a diet moderate low in protein without specific guidelines on water intake? Or is it B, advising a protein restricted diet and the use of prescribed salt substitute? Or is it C, recommending a diet moderately low in protein along with managing water intake as directed by the healthcare provider? Or letter D, indicating that no specific dietary limitations are necessary. Quite a long passage here. So I want you to read through the situation one more time and select your pick. All right, just pause your video, but I'm gonna answer the question now. So again, our scenario is on a patient with diabetes mellitus and also having dialysis, hemodialysis to be specific, for the renal failure. So what dietary advice would be suitable, most suitable for this patient during the intervals between dialysis session? So we're talking about the diet that the patient should be compliant about, even during the days that they don't have the dialysis. So for example, the patient will have dialysis on Mondays, every Wednesday, every Friday. So on a Tuesday, on a Thursday, on Saturday and Sunday, they're not going to have the dialysis. So what this patient should be eating or consuming on those days that they do not have the dialysis. So that's basically what the question is asking. So let's go through letter A, suggesting a diet moderately low in protein without specific guidelines on water intake. Well, you have a red flag here already. Remember, your patient has issues with maintaining a balance in their body. So this is a red flag already without specific guidelines on water intake. Quickly eliminate that because that is a dumb nursing intervention. Do not give some advice that you are not sure of. All right? So eliminate that one. And what we're going to do, supposedly, especially, is we're going to have to actually reduce the protein intake around this time. Okay? Have to reduce. And this is going to be prescribed by the physician. It's not the nurse's decision to just reduce. It is based on what the doctor has prescribed. However, though, aside from reducing the low intake of protein, we're also gonna manage the intake. We're gonna have to implement, we're gonna have to follow what the doctor has prescribed, which is basically managing the intake. So this is gonna make this option incorrect without specific guidelines. Letter B, advising a protein restricted diet and the use of a prescribed salt substitute. Okay, what is that? Advising a protein restricted diet is not the most suitable advice for the patient because while the protein restriction may be necessary, the use of salt substitutes right here, especially for those patients who really wanted to have a little bit of flavor in their food, for those who like to have some salt in their diet, that's no longer permitted. And so they probably are thinking of adding those, using those grocery prepared, like just the generic kind of like flavorings, like seasonings, like table seasonings, few drops maybe or so. These substitutes, salt substitutes, are really abundant in potassium, and this is a red flag. This should be eliminated right away because, again, they contain high levels of potassium, and this should not be consumed by the patient with the renal failure. Okay, so eliminate that as well. This is a common data that will test you as well if you're paying attention to the disease process. Now, what about letter C? Recommending a diet moderately low in protein along with managing water intake as directed by the healthcare provider. Sounds like a prudent nurse to me. Yes, that is the correct answer. When the patient with the diabetes mellitus undergo hemodialysis, they need to have proper dietary management. So again, moderately low protein along with managing their water intake as well. And in order for them to maintain that safe balance and also to prevent complications associated with overload, which is really common in those patients. And to just tell you, most of the patients that I receive in the acute care setting were having worked in the med surg for quite a while, over 10 years. Most of these patients have missed their dialysis. I'm not quite sure why they missed going to the clinic. Probably there was no available ride for them. Maybe the family member was not able to take them to the dialysis center. So maybe they had missed 2 sessions already or 3 sessions. That's unfortunate because by the time they missed the first dialysis session, they can readily go into the different changes already in their system. They can become confused. For those already demented patient or for those who had a pre-existing dementia or Alzheimer's, all the more that they will get confused, or maybe their level of consciousness will be affected. They will become lethargic most of the time. They will not be able to take their food. A whole lot of things can complicate. And so most of the time when these people will miss their dialysis appointments, they're already having some major neurologic manifestations. They are comatose, maybe. They're already in metabolic acidosis. They need to do those drug cocktail of administering the sodium bicarbonate, D50 with insulin, also with the calcium gluconate IV, and a immediate treatment like with a hemodialysis. So yeah, these patients really would come into the hospital with worse manifestations. And so our target really here is to make sure that they are adhering to the diet, making sure that they are following the moderate low diet in order to prevent the buildup of those byproducts of protein metabolism, okay? And also to prevent fluid volume overload. That's why we need to consider this, managing water intake as directed. And if we had answered letter D, indicating that no specific dietary limitations are necessary. Oh boy, that is so neglectful of an intervention. Eliminate that right away. Okay? That is a huge distractor right there. Seems like the nurse answering this question would have not learned anything from the BSN. No idea at all, no clue, should not be allowed to graduate from nursing. Yeah, I'm just being honest. And so our answer here again is letter C. And definitely our test taking strategy here is to make sure we are identifying patient specific factors, the medical history of the patient, the current treatment regimen, and also the patient has diabetes mellitus. It's going to be much more complicated. And so they definitely need to follow those dietary recommendations. Now, our goal here for this test question is to also eliminate those options that do not address the patient's needs. And like I've said, the fluid volume, okay? So we do not want those answers that not going to align with the management of diabetes with the renal failure. So again, letter D lacks guidance. Same thing with letter B and letter A, right? Very sloppy nursing. Now let's talk about the other strategy here. We really want to evaluate the relevance of the dietary advice. That's why we have to go through the care plan. Make sure that we are considering the dietary advice, the recommendation by the doctor or the dietitian. We want to make sure that all these complications are prevented. We don't want them. We really don't. Okay, let's go to, oh, we are done for the day. And so thank you so much for your attendance today. And again, we are inviting you or your friends to like, subscribe this video and also this channel. Make sure that you click the notification bell for all notification so you can get updated with the future schedules, and make sure that you attend in a daily basis because we're gonna discuss so many more concepts. And again, our YouTube classes will be live, and this is scheduled every 12 p.m. daily, 12 p.m. Eastern time to be specific. And we will be covering the different concepts in nursing, and also we will be rationalizing about 2000 NCLEX style questions. And make sure that you also enroll into our course at www.stancoastandclexcoaching.com. These so many have perks right there. Make sure that you avail as early as you can. It's only going to be up till the end of this month. We have 70% discount for the course, and you have everything here stated, and you can also check in the description below. Please write in your comments if you have any feedback. Make sure that you do that. And again, share this video to your friends who are trying to pass the NCLEX exam. And so thank you for your time, and you have a great day. Bye-bye.